Right now, somewhere in the United Kingdom and across the United States, millions of people over 60 are waking up every morning, opening their medicine cabinet, and taking a combination of drugs that their cardiologist prescribed, their GP renewed, and their pharmacist dispensed, all completely legally, all completely routinely. And a significant number of those people are experiencing fatigue that they've written off as aging, muscle weakness they've attributed to being less active, mental fog they've assumed is just what getting older feels like, dizziness when they stand up that they've learned to manage by moving slowly, and in some cases, symptoms they have never reported to anyone because they assumed this was simply the price of managing their conditions. Atorvastatin, Lisinopril, Metoprolol, 3 medications. Each one on its own is backed by decades of evidence. Each one has genuinely saved lives, and each one, when prescribed to the right patient in the right dose, is exactly the right clinical decision. But when these 3 medications are taken together in a body over 60, a body whose liver, kidneys, muscles, and nervous system all function differently than they did 20 years ago, something changes. The interactions are real, the compounding effects are real, and the fact that most patients on this combination have never had a proper conversation about what to watch for is a problem that this video exists to fix. Hi, I'm Dr. Alex. I'm an emergency medicine doctor, and after nearly 10 years in the A&E, I've seen polypharmacy, the prescribing of multiple medications simultaneously, play out in ways that individual specialists never fully anticipated when they each wrote their individual prescriptions. What I've learned from those experiences is that the question is rarely whether any single medication is right or wrong. The question is how these medications behave together inside an aging body. And that question is almost never asked in a standard 10-minute GP appointment. If you are taking any of these 3 medications or know someone who is, what follows is the most honest, most complete picture of this combination that I can give you. I promise to keep this grounded in real clinical evidence and real patient outcomes, not in alarm and not in false reassurance. All I ask is that you subscribe to this channel and give me the chance to earn your trust. If this video doesn't deliver genuine value by the end, unsubscribe. No hard feelings, but hit subscribe now and let's get into what you actually need to know. Let's continue. To understand what happens when these 3 medications interact in the body after 60, we first need to understand what each one is doing individually, because the combination problem only makes sense once you see how each drug works and how aging changes the way each one behaves. Let's start with atorvastatin, which is a statin. Statins work by blocking an enzyme in the liver called HMG-CoA reductase, which is one of the key steps in the liver's production of cholesterol. By blocking that enzyme, atorvastatin reduces the liver's output of LDL cholesterol, the type associated with plaque buildup in arteries, and the evidence base for this in reducing cardiovascular events is genuinely substantial. But here is what most patients are never told. That same enzyme, HMG-CoA reductase, is also part of the production pathway for a compound called coenzyme Q10, or CoQ10. CoQ10 is not a supplement trend, it is a critical molecule inside the mitochondria of every cell in your body, the mitochondria being the energy-producing structures inside each cell, and it is particularly concentrated in the cells that have the highest energy demands. Heart muscle cells, skeletal muscle cells, brain cells. When statin use reduces CoQ10 production, those high-demand cells are receiving less of the fuel that powers their energy output. In younger patients, the body often compensates adequately. In patients over 60, where mitochondrial function is already naturally declining, that compensation is less reliable. This is the biological foundation of statin-induced myopathy, which is muscle breakdown driven by statin use. It presents as muscle pain, muscle weakness, and in severe cases, a dangerous condition called rhabdomyolysis, where muscle fibers break down rapidly and release proteins into the bloodstream that can overwhelm the kidneys. Research published in Circulation has demonstrated that the risk of statin-associated muscle symptoms increases significantly with age, with higher doses, and in the presence of other medications that compete for the same metabolic pathway. Now let's look at Lisinopril, which belongs to a class called ACE inhibitors, angiotensin-converting enzyme inhibitors. Its primary action is to block the conversion of angiotensin 1 to angiotensin 2, which is a potent vasoconstrictor, meaning a compound that narrows blood vessels and raises blood pressure. By blocking that conversion, lisinopril relaxes blood vessel walls and reduces blood pressure. It also has protective effects on the kidneys in people with diabetes or existing kidney disease, and it reduces the workload on the heart in people with heart failure. These are well-established, important benefits. But lisinopril does something else that is less discussed. It causes the kidneys to retain potassium. Normally, the system it blocks, the renin-angiotensin-aldosterone system, promotes potassium excretion as part of its broader function. When lisinopril blocks this system, potassium accumulates. In most patients, this effect is mild and the kidneys compensate. But in patients over 60, whose kidney function is already declining, whose diet may include potassium-containing salt substitutes, and who may be taking other medications that also retain potassium, this effect can push blood potassium to dangerously elevated levels. High potassium, hyperkalemia, disrupts the electrical signals that control the heartbeat, and in severe cases, it can cause life-threatening arrhythmias. Research published in the Journal of the American Geriatric Society has identified ACE inhibitor use as one of the leading contributors to drug-related hospital admissions in patients over 65 with electrolyte disturbances, particularly potassium dysregulation, as a primary mechanism. Now, metoprolol. This is a beta blocker, a medication that blocks the effects of adrenaline on the heart. It slows the heart rate, reduces the force of the heart's contractions, and lowers blood pressure. It is used for atrial fibrillation after heart attacks, for heart failure, and for hypertension. Its cardiovascular evidence base is extensive and credible. But in the body after 60, metoprolol creates effects that are frequently misattributed to aging itself. Fatigue that genuinely blunts quality of life, cold hands and feet from peripheral vasoconstriction, exercise intolerance, a reduced ability to get the heart rate up during physical activity that makes patients feel unfit and discourages them from exercising, which is itself a cardiovascular risk factor. Depression and cognitive slowing, documented in research published in JAMA Internal Medicine, that in older patients is sometimes mistaken for early dementia. And in patients who also have diabetes, a significant proportion of the over 60 population, metoprolol masks the body's normal warning signals for hypoglycemia. The racing heart and trembling that alert a person their blood sugar is falling are blunted by the beta blockade. The danger arrives without the alarm. Here is where it gets really important. Each of these three medications individually produces side effects and biological consequences that the prescribing doctor knows about and accounts for in isolation. What is less systematically accounted for is what happens when all three are acting simultaneously on the same aging body. Atorvastatin and metoprolol together compound fatigue and muscle symptoms. Both contribute through different mechanisms, and the combined burden on mitochondrial function and muscle energy systems is greater than either drug alone. Lisinopril and metoprolol together both lower blood pressure, which significantly increases the risk of orthostatic hypertension, the dangerous drop in blood pressure that occurs when standing up, and in people over 60, orthostatic hypertension is one of the leading triggers for falls. Falls in this population are not minor events. Research published in the New England Journal of Medicine has identified fall-related injuries as a leading cause of functional decline and premature death in the over 70 population. And all three together increase dependence on kidney function for clearance, electrolyte balance, and drug metabolism in bodies where kidney function is declining by design. That is the biological landscape of this drug combination, and understanding it is the first step toward managing it properly. And just quickly, if this is giving you information you've never had before, please consider subscribing to the channel. It helps these videos reach the people who need them most. Let's continue. So let me name the central problem clearly, because I think it is important to understand not just what is happening biologically, but why it has been allowed to remain invisible for so long. The problem is not that any of these medications were wrong to prescribe. The problem is polypharmacy without integration. Each specialist who added a drug to your regimen was thinking about their area, the cardiologist about your heart rhythm, the endocrinologist about your cholesterol, the GP about your blood pressure. Each prescription made complete clinical sense from that specialist's perspective. But nobody sat down with the full list, your age, your kidney function, your muscle mass, and your daily experience, and asked, what is the combined effect of all of this in this specific body right now? That conversation rarely happens unless a patient is proactive enough to demand it. And most patients don't demand it because they don't know it's a conversation they're entitled to have. Let me show you how this plays out in practice. The most common scenario is what I'd call the normalized side effect pattern. A patient in their late 60s on all three medications feels genuinely exhausted most of the time. They have muscle aches that vary from mild to quite limiting. They feel mentally slower than they used to. They've stopped going for their afternoon walk because their legs feel heavy and their energy doesn't support it. When they mention these things to their GP, the conversation often leads to blood work that comes back broadly normal, and a conclusion that this is simply the experience of their age and their conditions. But here is what that conversation rarely includes: a direct assessment of whether the combined fatigue burden of metoprolol's beta blockade, atorvastatin's CoQ10 depletion, and lisinopril's blood pressure reduction might be driving the exhaustion. A review of whether the muscle symptoms cross a threshold that warrants checking creatine kinase, the enzyme released into the blood during muscle breakdown to rule out early myopathy, and a question about whether exercise intolerance induced by metoprolol is contributing to the physical deconditioning that is then being attributed to aging. The second pattern involves falls. An older patient on lisinopril and metoprolol, both blood pressure lowering agents, stands up from a chair or from bed, feels their vision grey for a moment, and either grabs for support or doesn't make it in time. This is orthostatic hypertension, and in the over 65 population, it is startlingly common in patients on this combination. Research published in the British Medical Journal has shown that dual antihypertensive therapy in older adults increases fall risk significantly compared to single-agent therapy. Yet many patients on this combination have never been specifically warned to stand up slowly, to pause at the edge of the bed, or to be especially cautious in the morning when both medications are at their peak effect. The third pattern is the one I find most concerning from a clinical standpoint. A patient on metoprolol for atrial fibrillation is also managing type 2 diabetes with insulin or a sulfonylurea. Their blood sugar drops during the night. Their body's normal alarm system, the racing heart, the sweating, the shakiness, is partially suppressed by the beta blockade. They wake up confused and severely hypoglycemic, and by the time someone recognizes what's happening, they are in a genuinely dangerous situation. This interaction is documented. It is known, but it is not consistently communicated to patients who are in exactly that position. None of the patients in these scenarios made a mistake. They took their prescribed medications. They trusted that the system had considered the full picture, that trust is not unreasonable. The failure is systemic, a product of specialist silos, time-constrained appointments, and a prescribing culture that adds medications more readily than it reviews the combined effect of what has already been prescribed. You cannot protect yourself against interactions you were never told exist, but now that you know, you can act on that knowledge. I want to be very clear before we go through these. Not one of these recommendations involves stopping or changing your medication without your doctor's involvement. I would never suggest that, and it genuinely isn't safe. What these recommendations represent is the framework for having a more informed, more complete conversation about your medication management, conversations that you are entirely entitled to have. There is a meaningful difference between a GP visit, where your prescriptions are renewed, and a visit specifically structured to look at your full medication list as an integrated whole. Ask for the latter. Bring every medication, supplement, and over-the-counter drug you take regularly. Ask your GP to look at the combined effect of everything on that list specifically in the context of your current kidney function, your age, and the symptoms you've been experiencing. Many practices now offer pharmacy-led medication reviews. These can be particularly thorough for exactly this kind of assessment. In the UK, your GP can refer you for a structured medication review under the NHS framework. Request it by name. This is not a conversation your prescribing doctor will necessarily initiate, but it is a legitimate and evidence-supported one to have. Research published in Nutrition has shown that CoQ10 supplementation in statin users can significantly reduce the severity of statin-associated muscle symptoms without affecting the cholesterol-lowering efficacy of the drug. A standard dose of 100 to 200 milligrams daily is what most studies have used. This is not a prescription medication and does not require a doctor's approval to take. But if you are experiencing muscle fatigue, weakness, or aching that began after starting or increasing your statin, raising this with your GP is entirely appropriate. Third, know the warning signs of statin myopathy. One of them is an emergency. Mild muscle aches and stiffness associated with statin use are common and usually manageable. But there is a more serious form of muscle breakdown called rhabdomyolysis that requires immediate medical attention. The warning signs are severe, unusual muscle pain or weakness that comes on relatively quickly, and urine that becomes dark, brown, or tea-colored because of the muscle proteins being excreted. If you ever notice dark urine alongside significant muscle symptoms while on a statin, do not wait for a routine appointment. This is a medical emergency and should be treated as one. Fourth, practice the stand-up protocol if you are on both Lisinopril and Metoprolol. Both medications lower blood pressure. Their combined effect makes orthostatic hypertension. The blood pressure drop that occurs on standing, more likely and more pronounced, particularly in the morning when blood pressure is naturally lower. The protocol is simple and takes 30 seconds. Before standing from bed, sit at the edge for a full 60 seconds. Then stand slowly and pause before you move. If you feel lightheaded, sit back down and wait. This simple adjustment prevents the majority of fall incidents associated with antihypertensive combinations in older adults, and it requires no medication change, only habit change. The hypoglycemia masking effect of beta blockers is a clinical reality that requires specific management strategies. Your diabetes team should factor this into your blood sugar targets, your monitoring frequency, and the medications used to manage your glucose. Sweating, which beta blockers do not fully suppress, often remains as a hypoglycemia warning signal even when the heart rate response is blunted. Know that this is your primary signal if you are on metoprolol, and monitor more frequently during any period of changed eating, illness, or increased physical activity. Non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, diclofenac, interact with every one of the three medications we have discussed. They reduce the kidney protective effect of lisinopril. They compete with atorvastatin's metabolic pathway. They mask pain symptoms that might otherwise alert you to statin myopathy. And they reduce kidney blood flow in a body that is already managing declining eGFR. Paracetamol, used at the correct dose, is the safer default for most pain in people on this combination. If joint or musculoskeletal pain is significant enough that you need regular anti-inflammatories, this is a conversation worth having with your GP to find an approach that doesn't carry the same systemic risks. Let me bring this back to what I see clinically because I think the real-world pattern makes this more concrete. In emergency medicine, a significant proportion of hospital admissions in the over 65 population are directly attributable to adverse drug events. And research published in the British Medical Journal has estimated that up to half of these are potentially preventable. The most common contributors are exactly the class of interactions we have been discussing. Blood pressure medications combining to cause falls, statins producing muscle breakdown that wasn't monitored adequately, electrolyte disturbances from ACE inhibitors going undetected, drug interactions that individually weren't catastrophic but combined produced a crisis. What strikes me, treating these patients, is almost never that someone made a reckless choice. It's that they were managing their conditions exactly as they were instructed, without the supporting information that would have allowed them to recognize when something was shifting in a dangerous direction. The broader context here is one that medicine is increasingly grappling with. The clinical trials that established the evidence base for Atorvastatin, Lisinopril, and Metoprolol were largely conducted in populations that didn't fully represent the over 65 patients on multiple concurrent medications who now make up the majority of people taking these drugs. Those trials established efficacy and safety profiles for each drug in relative isolation. What is still catching up is the systematic understanding of how these drugs interact when combined in a body that metabolizes them more slowly, whose kidneys clear them less efficiently, and whose muscle, nerve, and cardiovascular systems have less reserve to absorb the combined side effect burden. This is not a reason to distrust these medications. It is a reason to engage with their management more actively than the standard repeat prescription model allows. The patients I've seen who navigate polypharmacy best are the ones who treat their medication list the way a careful person treats their finances. They review it regularly. They ask questions. They don't accept that every symptom they develop after starting a new medication is simply aging. They push for the conversation when something doesn't feel right. And they work with their doctors to simplify where possible, because the research consistently shows that fewer, well-targeted medications in older adults produce better outcomes than longer lists of individually justified drugs. Atorvastatin, Lisinopril, and Metoprolol can each be exactly the right medication for the right patient. The question is whether the combination, the dose, and the monitoring are right for you at your age, with your current kidney function, and with the symptoms you are actually living with right now. You are entitled to that conversation. You are entitled to a doctor who reviews your full list, not just the condition that brought you in today. And you are now equipped with enough understanding of the biology to have that conversation in specific, informed terms rather than general concern. That shift from passive patient to informed participant is one of the most powerful things anyone can do for their long-term health after 60. And finally, if you found this video useful, please subscribe to the channel and help more people like you access this information.